Hello and welcome to the first session of the McKnights Workforce Development Forum. You've tuned into the true cost of post-acute care labor. I'm McKnights Senior Editor Kim Marcellus, and I'll be moderating today's event. Our speakers will be sharing some eye-opening facts about the cost of in-house and agency staffing that may help you refine your recruitment strategies. I'll introduce the experts in just a moment, but first we have some housekeeping to take care of. If you have any audio problems during today's presentation, please first check the volume control on your device. This is the most common cause of sound issues. You can also use the help button if your own troubleshooting efforts don't work. We will have time for a Q&A session near the end of the presentation. If you have any questions, please feel free to submit them starting now in the box on the left side of your screen. Today's slides are also available to download and print. You'll find those on the left side of your screen under the Handouts tab. Now, regarding continuing education. This educational offering has been reviewed by the National Continuing Education Review Service of the National Association of Long-Term Care Administrator Boards. It has been approved for 1 clock hour. However, you need to stay tuned into this event for its entirety during the original broadcast to receive a certificate. You can track CE requirements through the course completion tracker, which is accessed to the last icon in the area below the open webinar panel. Once you have achieved 50 viewing minutes, a View Certificate button will display, and the required viewing duration will have a green checkbox. You can then view or save your certificate. A copy will also be emailed to you afterward. We'd also like to note that this program is made possible by support from IntelyCare. To learn more, please visit www.intellycare.com. And now let's meet our presenters. David Copins is co-founder and CEO of IntelyCare. Under David's leadership, IntelyCare has grown to work with more than 30,000 nursing professionals and 1,600 healthcare facilities, including many skilled nursing operators. He came to staffing after holding leadership positions at other large organizations, including Virgin Pulse and UPromise. Deirdre Bagett is a partner at consulting firm Oliver Wyman. In the health and life sciences practice, she specializes in developing strategies to help clients make the shift to value and consumer-centric healthcare, value-based service offerings, and payer-provider collaborations for multiple health systems. She's also been hands-on with the LTC staffing analysis we'll be covering today. We're glad to have you both with us today. And with that, I'm going to turn it over to Deirdre to get us started.
Thank you, Kim. Welcome. We're so delighted to be here this morning with all of you, and I want to thank my colleague David Copins for partnering with me on this session.
Yeah, thanks. I think this is going to be a great webinar, and appreciate all the research you guys have done.
Thank you. So just briefly about our research, Oliver Wyman and our sister company, Mercer. So Mercer is the largest HR and benefits consultancy in the world, and we leveraged our partnership with them to do much of the research that you're going to see here today. If there are any questions or want more detail on some of the research and findings, we're happy to provide that. But in terms of what we were aspiring to do in this work was really to understand the true cost of post-acute labor. Obviously, post-COVID, we are in a very unprecedented time with the workforce. And so the research team was interested in really getting under the hood and understanding the true cost of post-acute labor. I am a nurse by training and have done quite a bit of work in staffing, both in the hospital environment as well as in post-acute care and SNF settings. In terms of exactly what we looked at, so we looked at occupancy rate, revenue opportunities. We really wanted to understand when we don't have enough staff, what is the impact on the business operations as well as revenue. We looked at most of the major job categories that would be relevant in post-acute care, so RNs, LVNs, and LPNs, as well as CNAs. And sorry, I'm having some technical difficulties. And then we leveraged, as I mentioned earlier, our partnership with Mercer on the HR side of things. In terms of takeaways from our research, first of all, as it relates to lost revenue, and on the post-acute side, when we don't have enough staff, in 2022, Oliver Wyman and Mercer estimate that the loss in revenue is roughly $19.5 billion from patients that were not able to admit to post-acute facilities due to staffing shortages. Occupancy rates in post-acute are still down. They're also down in acute care as well. Kim, I am having a hard time here with the screen. A second. Bear with me a second. Having some technical difficulty here.
Deirdre, would you like me to try to advance the slide for you?
I'll let you after this. It seems like it's freezing as I go. So maybe that would be better.
I could do that. I'll take care of advancing the slides. Thanks.
Okay, thanks. Total cost of full-time nursing, and we're going to show you some of this data from our analyses, showed an estimate of 1.9 to 2.2 in terms of hourly wage for a full-time clinician. And I would say that is up. Prior to COVID, what we saw was about 1.4, 1.5. So in terms of total cost of full-time clinical staff, significant jump in COVID and post-COVID. And then we'll get into some of the data in our research in partnership with Mercer around unmet needs of the workforce, highest levels of burnout ever, and the correlation to retention, turnover, work-life balance. If we can move to slide 8, David. In terms of where we're at, so we conducted a qualitative survey with over 1,500 post-acute clinicians. On the left, you see 26% of nursing professionals are considering leaving the profession. And this whole notion of working over and picking up extra shifts has, in much of our survey work, has been sort of one of the major themes that has come out of the work, where nursing professionals feel as though we assume that they'll pick up an extra shift, that they want to work an extra shift. They really feel as though we don't have their back when we are, forcing them or pressuring them to work increased hours. 60% of our survey respondents cited being short-staffed as one of the major reasons for leaving their job or leaving the profession. And then overwhelmingly in the survey, almost 100% identified lack of flexibility, work-life balance as one of their major top concerns. You see the quote there on the bottom left. On the right of this page, and this has really changed over the last 20 years, but this is the first time where more than half of RNs, so 62% of RNs, would not recommend the profession to their children. That number is actually higher among physicians, if you can believe it, but it speaks to the crisis that we're at coming out of managing a pandemic. But for the first time ever, nurses are not, more than half are not recommending this to their family member. And the same story plays out with LVNs and LPNs, as well as CNAs. Next slide.
Yeah, I just wanted to add to the point, just to reiterate that, in fact, this was a survey you did to just post-acute nurses and nurse assistants. So
yep.
That, because we're seeing a lot of that same data in acute care, and just want to make sure that it's relevant to this audience. Yeah.
Yes. Yeah. So this is all the data that you're seeing here. Thank you, David. Good call out. Yes. So David's point that this is all post-acute respondents is absolutely correct. I would say if there's while there are many similarities, I think the reliance that we have in post-acute on the CNA workforce is greater, and we'll talk a little bit about the implications there. But otherwise, yes, agree. Similar themes, but this survey was directed at post-acute providers. Moving to slide 9, what we wanted to do here is really understand. And so you'll see here on slide 9, we asked, we were trying to understand the value proposition for the post-acute workforce. And our concern as a firm is that the national trend in increasing minimum wage has contributed to an erosion in the value proposition, particularly for CNAs and MAs, where they can, leave healthcare and go to a Chipotle or a Best Buy and potentially get $2 or $3 or $4 an hour more. So the changes in minimum wage laws and major movements in this segment of the population, we think has significant impact, particularly on CNAs. So what you see here is from our survey, pay was still rated number 1 in terms of employee value proposition. When you get under the hood of that, we do another survey, a conjoint analysis on unmet needs. I would argue, and David, you should push back if you feel differently, I would argue that we've trained our workforce to ask for pay first. When you get under the hood a bit, what you really start to hear are things about work-life balance, the stressors of longer shifts and staying over, the emotional demands of caring for patients, and particularly patients and families during COVID. A lack of flexibility as I don't probably need to remind you all, but 90% of this workforce is female. Many of them are working mothers, so flexibility matters, and it became a challenge for working moms during COVID when their sources of daycare were not available. So while pay is still number 1, it was still number 1 in our survey among post-acute care workers. A closer look when you do a conjoint analysis suggests that right up there are things like work-life balance and their emotional well-being. Anything you would add, David, on this slide?
Yeah. I think what's fascinating about this is not surprising, pay is always number 1. But when we do our surveys of our own nurses that have joined IntelyCare, we ask them, why are you joining IntelyCare? And every single time in the last 5 years, this is not COVID related, but every single time, the number 1 is schedule flexibility. Schedule flexibility. Number 2 was also related to that in work-life balance. Number 3 was pay. And I worry that a lot of our, the client, the facility network here believes that they're all leaving, to come to agencies for pay. But that is fundamentally not the case. It has always been the schedule flexibility. And so where you see this emotional, work-life balance, emotional demands, flexibility, those are all, heavily also interrelated, of course. And in this case, if you go outside of the people that have stayed, they still kind of prefer the pay as number 1. But got to remember how important that is, and see if we can devise ways to provide more schedule flexibility for their own staff.
Yeah, that's a great point. How do you answer the question, David? I'll push on this a bit. So what I hear when I talk about healthcare executives needing to reconceive clinical scheduling, the pushback that I get is, Deirdre, we're a 365-day-a-year business. Our patients are here day and night and weekends and holidays. Yeah. And so share your perspective on this. From my perspective, I think we haven't worked hard enough to design flexible models. I think there is more opportunity than we've really explored in terms of how do we use technology to enable more flexible scheduling. What could a 4-day work week look like, or half shifts or 8-hour shifts? But I do get pushback from executives on this flexibility. And what I would say is, our clients that have been willing to do some really out-of-the-box thinking around what does flexible scheduling look like, or, what is, the ability to cancel a shift within, 8 hours look like, or, what does flexibility mean defined by our employees? They have had more success and more progress. I'm curious your thoughts, because I certainly get pushback on this topic.
Absolutely, and I can understand the pushback. If you're fully staffed at 100 clinicians in your facility, then you're going to think, well, geez, if I give them all the flexibility, I'm going to be short-staffed again. But the reality is, and this is what we discovered in our process, is you can attract more people. And so you go from 100 to 120 clinicians, and then you still have your full-time staff. Call it 80% are still going to be your full-time staff, and you can schedule them appropriately. But there's a more fluid sense of the less attractive shifts and the ability to add incentives for those, and that's where you start to be able to fill in. And if you can offer a higher pay for an unattractive shift, but to somebody who can say, you know what, I just want to pick it up when I want to, you're going to attract a higher number of people in the workforce. Anyway, it sounds simple. It does require, a lot of thought, but it's worked out, extremely well for us.
Yeah. The one final add before we move on is I will say, in order to offer the type of flexibility that we're talking about, it's very difficult to do that manually. Technology can enable this, and having predictive tools to plan for, Wednesdays or Thursdays are our bigger days for admissions. I think doing this manually is very challenging to anticipate the demand and variability while also allowing a level of flexibility. And that's where I think we as a staffing industry have to give staffing offices better tools to offer this level of flexibility, because doing it manually and, dialing 100 people every day is untenable. It's not well received, and it just, makes it really challenging to offer the level of flexibility that essentially our workforce is demanding. Moving to slide 10.
I'll move this along. I agree with that. And, short commercial, we do have that ability now to offer that technology to manage your own workforce. So that was enough. Done with the commercial. But if anyone's interested, talk to us.
And moving to slide 10, so here we have occupancy rates, and this is something that we've been watching across all care settings. But on slide 10, you see the occupancy rates in SNF, not surprising, in part due to, COVID fear, but certainly they have not returned. And you see the decline over time there on slide 10. So this is more of the revenue side.
Yeah.
Go ahead.
Well, and then this is the question. We hear about there's a lot of pent-up demands out there, that hospitals can't discharge to long-term care facilities, that families are waiting for a spot. We know that oftentimes facilities are saying, let's hold our census levels as it is, because we just don't have the staff. And so some of that, from what we understand, is just a choice for the facility, and not necessarily that there's not enough demand. But it certainly, the occupancy has not rebounded. It has in some spots. I know Genesis says they're above pre-COVID levels, but there are definitely others that are still way behind.
Yeah, good point.
Go ahead.
I do worry about this whole your point, I guess, about occupancy. If there is capacity, because certainly for SNF hospital partners, they are struggling as well. They they have more patients than they can manage, and so when they aren't able to to discharge, whether it's regardless of the post-acute setting, it has negative implications for hospital providers as well. And then on slide 11 is really sort of the math of it, but number of unoccupied beds times revenue. So when we show you our $19.5 billion in terms of lost revenue, that's essentially the math.
Next.
Yep. And so on slide 12, so this was our analysis that breaks down, and we actually looked at it by region. So we looked at and modeled SNF estimated unrealized revenue over a 3-year period. And you see there our projection for 2022, most of this driven by a lack of staffing capacity. For some, this number is surprising because I think they don't, may not be thinking about it. But David, what are your impressions when you see these numbers?
I think in 21 with the $23 billion, there really wasn't much option for our client facilities. There just wasn't enough staff, whether it was from agency or direct. But what we are seeing in 22 is it seems to be more of a deliberate trade-off, and that's where I think I believe the rest of the data we're going to expose here is a helpful insight, which is the cost of bringing on agency staff has just been seemingly so high, and there definitely were high peaks at different times during the pandemic. The pay rates have dropped quite a bit so far this year, and I think the deliberate trade-off right now may be considered to be financially, just not consistent with trying to achieve a profitable business. But that's my thought. Let me pass it on to the next here.
Thank you.
Did I get that? Yeah.
Yeah, and so then when you break it down by region, by day, really what this equates to is roughly $2,000 to $6,000 per day in lost revenue, lost ability to take admissions due to staffing. So, when we hear post-acute providers talk about, margin impact post-COVID, it is about managing costs, but it's also about pulling through revenue and the revenue side of the picture. And so when we are not able to staff, it has absolutely, a daily impact on revenues. And this is a piece that I really think that we've got to solve for, because for many of our post-acute clients, they're suffering on the revenue side and they're also suffering on the cost side, right?
Yeah, exactly.
Okay, and so if we move to 15, we can get into some of the data from our research. So what our team endeavored to do was really understand, when you look at a nurse or an LPN or a CNA, what does it really cost? So when I think for many, we think about salary and benefits, but when you look at the growth in recruitment cost, as well as retention bonuses, changes in retirement, when you really look all in on an hourly basis, the fully loaded cost of a new employee is about 1.9 to 2.2, and as I mentioned, that is up from 1.4 or 1.5 pre-COVID. And so we'll get into some of the detail, but we have this broken out by major job category: RN, LPN, and CNA. And I would say all of this picture, whether it be retention efforts, recruitment efforts, wages, we, Oliver Wyman, do not see this rolling back. And so I'm going to get into some of the details. Moving to slide 16, starting with CNA. So on the far left, you have sort of the representative contingent labor cost. On the on the right, what we were interested in understanding is beyond the hourly wage, what is the true cost? And so you see all of the drivers, benefits, retirement, PTO, FICA. The big changes have been recruitment and retention cost, and then obviously continuing ed. And so you see here on slide 16 that when you look at the fully loaded cost, it's significantly higher, obviously, and oftentimes higher than even contingent wages. And we have that broken out for RNs, CNAs, and LPNs as well. David, anything you would add to this one?
Yeah, I mean, if I'm on the other side, I start to get really skeptical. Okay, so I start thinking, okay, well, I don't pay $19 an hour. But do you? So this is the question, because if you're paying $16 or $17 an hour for a CNA, but then you end up paying, quite a large differential if you need people to kind of work overtime, or or even handing out gift cards, which I seem to hear about quite often, it actually ends up being quite a bit larger than 19. But let's just say for the moment it's 19. But and let me also preface all this. Oliver Wyman also developed a calculator that you could actually punch in your own numbers and see what it looks like. But let's just say 19 for a moment. That includes all the overtime and everything else. And then you say, all right, well, health benefits, that comes right out of the Mercer database. So this is inarguable. It is what it is. It's the 4, it's the 1, it's the 2, it's the 2. It's these here are your hard costs that come right out of the database, thousands of facilities. And so as much as you would like to be able to say, well, we don't give that much PTO, that is the average for all the facilities in this database. The part where you might want to start to say, I don't know, do I really spend $3 an hour on recruitment? So if you have average level of turnover, then you probably do. But again, I don't pay retention bonuses. But then again, there are different ways of that's a kind of a catch-all category for any sort of incentives with your current, team. And then the L&D here is also just retraining new staff. You bring new staff on, they have to go through training. 2 months later, they quit. You got to bring more staff on, and they got to retrain. So, all right, here are your hard costs. These are a little more fungible based upon how you operate. So you may never actually be at a true 37. But I think the point that I think was fascinating when we discovered this was, if you get your head around this idea that bringing on a CNA from an agency is it's a few bucks more or a few bucks less than it is having my own my own employee. If it's kind of right around that, then the world starts to open up a little bit. Strategic decisions start to come through. So this is the kind of the big aha when they presented this information to us.
Yeah, thank you, and good clarification on the wages. The wages include overtime, holiday pay, shift differentials, and that's what we hear very often is executives just didn't really understand. They didn't understand the training cost. They didn't understand the turnover cost. And so that was really the intent of this research, is to really get at what the true costs are so that you all are better informed to make decisions about how you staff your organization. Let's move to slide 17, David. Does that sound okay?
Yep.
And so here we also looked at overtime cost versus contingent labor. So we heard lots of concern about the cost of contingent labor versus overtime. Our evaluation is it's roughly flat. It's roughly about even, and you see that here from our analysis, are broken out by job category.
That's really interesting. Yeah.
Moving to slide 18, and so this is where we've had many questions about what is the anticipated labor cost growth. So we saw 4 recent union contracts get signed around the country, and the price points that they came back at in terms of annual CAGR and in terms of labor costs was very consistent with this analysis that we did with Mercer. So what you see is really historical pre-COVID average increases, RN, LPN, CNA, and then post-COVID, what we anticipate over the next 6 years. RNs at roughly 6% growth, LPNs slightly higher at 7%, and CNAs the highest at 9.3%. So we get many questions about, are the numbers going to go back to pre-COVID, and they really are not. And we have 4 pretty large data points over the last 4 months of contracts for these union contracts that the percentages are pretty consistent here. And obviously those might be anticipated a little bit higher, but these numbers are what we would anticipate over the next 6-7 years in terms of annual rate increases for these job categories. David, did that surprise you at all?
Yeah, I did not expect that steep of a curve. We certainly had, it's been bad news for these facilities, just the real wages of increases. But dang, yeah, that trajectory just continues to go. So that was a little surprising.
Yeah. Moving to slide 19, if we can.
Mine might be frozen now. Jackie, can you go to 19?
Thank you. In terms of recruitment costs, so this gets back to, sort of the supply demand.
Did it advance for you? I'm sorry, I'm still on 18.
Yes.
You did? Okay.
Yes, thank you. So we do anticipate continued increased investments required for recruitment, both on recruitment and retention, but here you see the investments for recruitment over the last 10 years, and we anticipate a continued need for higher investments. You see here, most organizations are spending about 8% to recruit an RN, 5% LPN, CNA, 7%. If we move to slide 20, this is the retention story that we believe is really important. The turnover numbers that we're seeing in post-acute range from 40 to 50%. We have to, and this is where the flexible scheduling we think is a really important retention lever. But this retention issue in post-acute, getting to 50% turnover, so half your staff turning over every year, having to retrain, is very cumbersome. And in many markets, there just aren't enough workforce to actually support a turnover that high. And so we continue to see this. We keep hoping that it will that we'll see signs that it's coming down. There are a few states where we're starting to see the numbers come down a bit, but we anticipate a continued need to invest in strategies that enable us to sustain our workforce. David, do you have thoughts on this?
Again, I think that you hit it head on earlier, which is we've trained people to kind of focus on the dollars. Can we change, the focus? Find other things that that make them want to kind of remain engaged, that will keep them, that want to remain in employment, full time in their position. And I do keep coming back to flexible scheduling, work-life balance, that kind of thing. And it's cumbersome to be doing that. I knew a facility or a group that had 3 facilities, and they created their own PRN pool, but they had a full-time person managing that PRN pool. And I keep wondering, was that economic? Did that make sense? I hope, it probably did, but it's cumbersome. So, but I do think that the focus has got to be more on creating a more enticing environment to work. And I don't mean environment like, oh, let's put snacks in the kitchen. I mean environment like just knowing what nurses and CNAs and LPNs really care about in their lives, and then trying to find a way to actually give that to them.
Yeah, agree.
Otherwise, this is good. This is very bad news. Already the wage rates going up, projected to continue to go up is going to be, heartbreaking. But this is also tough.
Agree. Let's move to slide 22 and get to a little bit of sort of what's at the heart of this. So as I mentioned earlier, we, Oliver Wyman and Mercer, have been very closely monitoring the well-being of our healthcare workforce. And I think the biggest surprise for me very early on in COVID was that people weren't necessarily leaving their employer. They were considering leaving the profession. And our research in this project can continue to illuminate that issue. And it's bigger even than nursing and CNAs. We see it in pharmacy. Right now we're seeing it in physical therapy. We're seeing it in physicians. And so the historical levers and playbook that we used pre-COVID, we really have to reconceive the way we engage our workforce. Otherwise, they will leave. And the historical notion that people came to this profession, it's their passion, and they feel a sense of purpose and fulfillment. What we learned in our research is there is a breaking point, and when our workforce is, feeling as though we don't have their back, and all we're interested in is getting them to cover the next shift, if you will. There's actually a lot of anger and frustration and exhaustion in our workforce. And so how do we really get after reducing burnout, improving work-life balance, and thinking about the workforce as our most important asset? And how do we meet their needs holistically? I would say if there's one takeaway that you have from this presentation, it would be that this is your most important asset. And the transactional levers historically don't really get at helping our workforce to actually manage their life better. But you see some of our data here. Increased work hours. Again, we see this across all job categories, even beyond nursing. The average number of work hours per week. And I would say, and I'm a nurse, so I work lots of doubles and weekends, and I have lived this early in my career. And what we heard in our research is that our employees feel like we don't have their back when we are asking or demanding or pressing them to pick up extra hours or work extra hours. And so 52-hour work week for nursing assistants in an already very challenging job and very physically demanding job. The result is they feel as though we don't have their back and we're not looking out for their well-being. And then obviously we've talked a lot about working short, but the other backlash that we saw in the research is when we ask our workforce to work short, they don't interpret it as, my employer did the best that they could and we're still short. What they interpret it is again, my employer wasn't looking out for me. My employer doesn't care about me. And so loud and clear in the data, when we look at, why people leave, for gig work is that they didn't feel as though their employer had their back. And so I think really important for us to not assume that we're, going to always be able to tap into our existing workforce and expect that they would just work more. The outcome that we saw in our research is that there's quite a bit of resentment and feeling that, that their employer wasn't looking out for their well-being. Anything you would add to that, David?
No, I think that's spot on. I think it's spot on, Deirdre.
Okay. And then
move on.
Let's move to slide 23. So for us, the way that my team thinks about our future workforce, what we think is that most of us have a vision of a stable staffing model and that would not include contingent or contract labor, regardless of the type, physical therapist, occupational therapist, nursing. What Oliver Wyman sees is that if you really look at the demand in our industry, it is uneven. So in the summertime, demand is lower. During flu season, demand is higher. When we see organizations that are performing well and have strong revenue, they have some percent of their workforce that's PRN, that's what they work. So they are, a guaranteed number of shifts per year, that it gives them a level of flexibility when people are sick or out or whatnot. But there's also a realization that, some percent would be contingent labor, and that would be give us the ability to flex during periods of variability in supply and demand. And I personally, having lived this, I lived thinking that, agency workforce was not a good thing. It was more expensive. I don't think that way anymore today. I think the way our practice thinks about it is, particularly in hard-to-fill categories, and there are several in healthcare, the ability to build relationships with a contingent workforce and integrate them into your team, it gives you a level of flexibility that drives the retention that you desire. And so what we propose is that we as an industry really rethink our staffing model to give us greater flexibility. And that means really a high percentage of PRN employees. And so in 2 organizations, I ran PRN pools that were several hundred employees, and they were very happy. They wanted, to work a few days a week. But we could predict and project how many shifts we would get for them per year. And then secondarily, rethinking contingent labor and building relationships with agencies and integrating those individuals into your team. We think that's the future. All of that, I would say, enabled by technology that allows for staffing offices to predict peak demand, predict seasonality, thereby offering greater levels of flexibility. David, additional thoughts?
No, I think that's right. I mean, it sounds counterintuitive coming from us, but we really just want to find a way for our client facilities to have, to not to get to the point where they neither can accept more, more residents and patients, or that they are burning out their staff. And so if we can do that by stack of augmentation occasionally, or by providing technology that helps them manage their own pool, their own PRN pool, or whatever, it might be, supporting them on their full-time, staff recruitment. The objective is all going to lead towards the same thing, which is let's get to and I hope that the kind of mindset changes if you can kind of think about it in terms of, hey, someone who's coming from, a staffing company, the dollars per hour, as high as it seems on the face, is probably just a few bucks more or a few bucks less, depending on how you operate your business per hour. And with that in mind, it does kind of open up the possibility of let's be a little more strategic and plan, more through a partnership standpoint of how we might best be able to support your own staff so as not to kind of drive burnout and to get to the right mix that works best for you. So I agree with everything you said.
Yeah, thank you. Again, I think, COVID has taught us many things, and, right now, our workers are king, and they are, our most important asset. And so really understanding what they're not saying when they say it's money, I think is really important. And I think, coming back to the reality that we have a predominantly female workforce, and they need flexibility. And those post-acute providers that are able to think out of the box and be willing to be creative will get more than their fair share of the workforce. And those of us that struggle to evolve the way we think about our workforce will be challenged. And so I will leave you all with that, and we can open it up to questions, but I think the onus is on us to hear our workforce, and what they're asking for is greater flexibility and acknowledgement that many of them are, working parents, and we are not like other industries who can go hybrid pretty easily, or hybrid part-time. We're watching these, major corporations like Google do large experiments around hybrid. That really isn't an option, right, for, our clinical workforce by and large. I think there are some things where technology, as I mentioned earlier, can enable a greater level of flexibility there. But for us in healthcare, we really have to define flexibility because we're not an industry post-COVID that's going to be able to, be a hybrid or virtual, completely virtual. That's just not realistic, right?
Exactly. Yeah. Hey, we definitely got a lot of great questions I'm seeing right now. So, Kim, coming back on here.
Absolutely. I am here. Thanks, David, and thanks, Deirdre. Really appreciate it. And I'm going to start with a question that I think is maybe your whole goal in sharing this data with our audience. Obviously, this relationship, or the idea of the relationship between the skilled nursing provider and the agencies, has been one kind of billed as this contentious issue, and obviously folks have asked for government intervention. So I'm going to start with a question from Lorianne, who says, are there any government plans in the works to help SNFs so they can compete with agency? What's your perspective in response to that?
I'll give mine, and I did spend a number of years.
I have no perspective other than I really hope something happens, because it is a really tough world out there. So, but I'm not close enough to it. So, Deirdre, go for it.
Yeah, there's certainly, both both among hospital associations and post-acute providers, there's certainly many proposals. What I'm not seeing, though, is meaningful movement in terms of annual rate increases from the major public payers. So while I understand, and I don't think this labor cost issue is going away, and the labor challenges are going away, I don't expect that the feds have some magic bullet. I think we have to figure this out ourselves and help our legislators and policymakers. I just am not, this is not, and it isn't unique to our industry, quite frankly. It's just hit us harder than other industries. So I personally, my guidance would be to, continue to work with legislators. However, I wouldn't count on that. I think we all have to own this, and owning that in our own organization. But I share David's concern. It's a really tough time, and I think there have been many calls for at a federal level for intervention. I'm sorry, I probably sound cynical, but I'm not.
Well, I'm gonna jump in and pile on a little bit with the cynical aspect, because I was just with ACA in DC, and some of the conversation there obviously was regarding FTC getting involved. And what I'm hearing is that the FTC has internally said it doesn't have evidence of agencies colluding, which would kind of be that factor they might need to intervene at the federal level. So it sounds as if any intervention would happen at the state level, and we know states have been hit or miss whether they are responding to providers and coming up with some kind of legislative response. And so, Deirdre, I would say I agree with you that the take is going to be, if you're in a state that's not acting, it's really going to be up to you to figure out how to work with the existing agency environment and make it work for you, and be smart about how you approach it, which, again, I think your data helps folks to see what the actual situation is, rather than just how that emotional response to it, I guess.
Yeah.
So next question is from Scott, and this one's addressed to David. You mentioned an aha moment earlier. Is the aha that a company may see a value in contingent labor?
Well, there's always been sort of a necessary evil kind of belief around contingent labor coming through agency, and I think what sort of aha to me was just the fact that if you put in all of the real costs, and when I say real costs, I mean the costs that actually go away when you don't have that employee. So it actually ends up becoming so much closer to what an agency is actually charging, and that aha means if that's real and all the evidence, and I don't think Deirdre would put her reputation on the line and feed us incorrect data, but if that's real, then I think it opens up a different thought process internally, which is, should we just use agency then to increase our census? Because we know the demand is there for census. It wasn't for a large part of COVID, but it absolutely is there now. Should we use that and then use the expansion to kind of get us more to profitability? Now, I will never argue against the notion that you want your own staff for consistency and quality, and I believe that. But if you can, manage to 10% or something with an agency, 15% if it's really a difficult situation, then you would find that you could probably get closer to profitability. Certainly, that's what we've seen on both sides. Some are intentionally holding back, and they're in a negative, margin territory. Some that have embraced using contingent staff and found it to be that they're now a profitable company. So I would think more about using contingent staff as a revenue driver for you, as a way to do that. And if you could do that, then fantastic. And I think that was one of Scott's questions here.
The one add I would have to what David shared is my concern when the doors are not open or the lights are on is that there are a number of providers who are stealing market share right now because they are taking aggressive approaches. They are ensuring that they can be open and available for their, acute care partners, physicians that are referring. I worry about the longer term market share impacts when we turn patients away or we don't have access. I think those referral relationships are really important, and it impacts our upstream partners. So if it were me, I would double down on being able to have open access just to ensure my market share. And obviously it's the revenue piece, but I think there's a longer term implication when we, turn away referrals. I worry that physicians would stop sending them. There was one comment that and we have a payer practice, so I do want to offer something on this question about reimbursement. I would say many provider clients are raising rates with payers just due to these increased labor costs. Payers understand that they're trying to work collaboratively with their payers because they understand that some of these labor costs are not moving back. I wish the feds were doing more, frankly, but I do think this question about raising rates is continuing to come up, and I think there are a number of payers and providers that we're seeing work collaboratively together to try to solve this. So I do expect rate increases.
And I would say with our audience, I mean that's the challenge, that there are so few private pay patients in skilled nursing at this point that unless the government reacts, then seeing that $55 an hour for an RN in 6 years from now is pretty frightening. And I guess I would just add too that the issue with if Medicare rates, once we get the PDPM adjustment, that's on everybody's mind right now. But whether rates go up in years to come, it's always a couple of years behind what's actually happening on the ground because of the cost reporting factors. So, you've got to expect that if we have continued inflation and wage rates continue to climb like you predict, that you're not going to have everything you need. Again, you've really got to figure out where you can make those cost adjustments so that you can get the staff, but do it smartly and plan, because I think that's, again, what you guys are focusing on throughout here, that the less that you're doing last minute and scrambling, the more empowered you are as a hiring manager to actually know who you're going to be bringing in and have some consistency and to limit how much of your work staff is something you have no control over. So,
Absolutely.
all right, I'm going to do one more.
What you're getting at, though, is for our listeners is this is about strategic trade-offs over the next 2 to 3 years. This picture doesn't get better in 6 months, right? So I wholeheartedly agree, and we have to have our eyes open and make really important strategic trade-offs, because you're 1,000% right that it will be a few years before any sort of reimbursement catches up. Sorry, David. Go ahead.
No, I'm just saying there was a bunch of questions we haven't got to. And I don't know if there's a way to tell people how to contact me, but if they're interested in talking to me or Deirdre, I would very much welcome it. I miss Sharon, Nancy, Maria, George, a bunch of good questions.
Okay, hold on just a second, David. I do want to ask you one last question, but I'm going to give you 30 seconds to answer it. Roy just wanted to have a recap. What's your best concise definition of contingent wages? What does that include?
Yeah, Deirdre, your question.
Wait, contingent wages?
Yeah, I think on the slide it said contingent wages was one of those. Because I'd say the short answer to me is it's just the hourly rate that an agency is charging, and if they're charging you any other fees, then you have to include that in. No, but they shouldn't be. But if that would be the total cost. That's the comparison point, I think. Because the 29 that's in this study is not what the nurse or the CNA gets paid. It includes all of the other taxes and our own taxes and healthcare and all those other things that we have to pay for. That includes that. Yeah.
Okay, terrific. And if either of you want to respond more to Roy, you can. And I just am going to have to close it out here, but I will remind everyone, if you asked a question and it wasn't answered live, that the team from IntelyCare and Deirdre can reach out to you and provide answers to those questions. So I, again, want to thank our audience for coming to this first session of today's Workforce Forum. We do have 5 more sessions today and tomorrow. So if you have time, please come back for more staffing and workforce strategies. The next one is starting at noon Eastern today, and you can stay ahead of the staffing shortage with workflow automation through the same registration page. If you'd like to watch this session or any of the others on demand, a recording of each will be available shortly at McKnights.com/060822 Staffing Online Forum. And of course, we'd like to give our special thanks to David Copins and Deirdre Bagett for walking us through the issues, the information, and for providing their advice on how to approach this very challenging staffing environment. Thanks also to our sponsor, IntelyCare, which you can learn more about at www.intellycare.com. And finally, we want to thank you, listeners. You've been a big part of a smart conversation this morning. We appreciate you tuning in. This is Kim Marcellus for McKnights. Have a great afternoon.